So we will move to our next speaker. I'm happy to invite Dr. Samantha Kover from Australia to present her study about personalized supportive care for patients receiving 5FU, interim analysis of a multivariate S&P risk prediction for GI toxicity.
Thank you for the introduction. I'm not quite a doctor yet. I'm in my final year of my PhD, and this study forms the basis of my PhD research. So we'll have no disclosures. So the drug of choice for this study is 5-fluorouracil. So for those that don't know, 5FU is an anti-metabolite chemotherapy drug that inhibits DNA and RNA synthesis. So it's commonly used in treatment regimens for breast, upper GI and colorectal solid tumours. So although it's a highly effective chemotherapy drug, 20 to 40% of patients that receive 5FU will experience GI toxicity. So this includes oral mucositis, diarrhoea, nausea and vomiting. Of these patients, a subset will experience severe GI toxicity, graded as 3 or above on the National Cancer Institute's common terminology for adverse events. So these patients will need treatment delays, dose reductions, and some will need to cease treatment early. It also induces secondary consequences such as pain. Some patients need to be hospitalised, which is an additional financial burden on the healthcare system, and most importantly, it decreases a patient's quality of life whilst they're on chemotherapy treatment. So most of us are aware of the 5-phase model by Steve Sonis of mucositis. However, I'll quickly briefly go through it. So following 5FU chemotherapy, we get the release of damage-associated molecular patterns or DAMPs from injured and apoptotic cells. We also get the release of pathogen-associated molecular PAMPs or PAMPs from colonised bacteria and microorganisms. So PAMPs and DAMPs are recognised by toll-like receptors, in particular toll-like receptor 2 and toll-like receptor 4. So following recognition, toll-like receptor 2 and toll-like receptor 4 initiate a signalling cascade through the toll interleukin-1 receptor, or TIR, domain innate immune signalling pathway. So this pathway activates nuclear factor kappa beta, which then translocates to the nucleus and upregulates the gene transcription of IL-1 beta, TNF, and IL-6. Upregulation of this gene increases secretion of pro-inflammatory cytokines, which increases the inflammatory response and also enhances primary mucosal damage. So the problem that is commonly seen in clinic is that we have two patients. So demographically, they're very similar and they have no significant medical history. So they've both been diagnosed with left breast cancer and are receiving a 5FU-based regimen. So patient A has had a pretty good chemotherapy experience. They have mild fatigue and grade 1 nausea, whereas patient B has had grade 3 diarrhoea and has needed to be hospitalised. So the question is, why does patient B suffer GI toxicity and not patient A? So medically and demographically, these patients are very similar. So why does one have toxicity and not the other? Well, the answer is we don't know. So we need to identify predictive for severe GI toxicity risk, and this will allow us to personalise supportive care measures to reduce GI toxicity severity. So the development of GI toxicity is influenced by a triad of factors such as patient factors, treatment factors, and tumour factors. So of these factors, the most potential for source of predictors comes from genetics, in particular single nucleotide polymorphisms or SNPs in the before mentioned TIR domain innate immune signalling pathway. So our lab conducted a pilot study named the Salivary Predictors in Treatment, or SPIT study, in 2015. And in this study, in 34 patients, it identified that TLR2 and TNF SNPs, in conjunction with colorectal and gastric cancer, was predictive of severe GI toxicity risk. And the predictive risk model had a receiver operator characteristic area under the curve, or ROC AUC, of 87%. So like any pilot study, it needs to be validated. So part of my research is conducting the SPIT validation study. So the aim of this study is to associate SNPs of the TIR domain innate immune signaling pathway with severe GI toxicity in patients that receive 5FU-based treatment. So this is a retrospective study and compromises patients from a variety of locations around South Australia. So our patients are identified through our pharmacy dispensary lists, and if they meet certain criteria, they're mailed a letter of invitation. Once they're accepted into our study, we mail them a saliva collection kit, and we review their clinical case notes to collect demographics, treatment data, and toxicity data. From their saliva sample, we extract genomic DNA and send it for genotype analysis. So So far to date, we have 114 participants enrolled in the study, and this has been over a 4-year period. So to allow the comparison with patients with severe GI toxicity and patients with no mild toxicity, we classify our patients as no mild. So these patients had a grade 2 or less of GI toxicity based on the NCI scale I mentioned before. And patients that had severe toxicity were graded as 3 or above on the NCI scale, or they had a treatment cessation or reduction. So when comparing our clinical demographics, we found a significant difference in our 2 cohorts in cancer type. So our severe patients that had severe toxicity experienced more colorectal cancer, whereas patients that had no or mild toxicity experienced more breast cancer. This also linked with our treatment protocol, so patients that had severe toxicity generally had 5-FU as a monotherapy, whereas in our no mild group, most of the patients had 5-FU in combination with other drugs such as irinotecan and oxaliplatin. So to build the predictive risk model, we have our covariates of interest as well as our SNPs of interest. And each predictor is added individually to the model. So if it improves the model using an ANOVA test, it remains in the model. If it does not improve the model, it's removed from the model. So this is our predictive risk model that we have to date. So 105 participants are included in it. So the model has identified 2 IL-1 beta SNPs as predictive of severe GI toxicity risk in conjunction with colorectal and gastric cancer types. So this ROC AUC is slightly lower than our pilot model of 82%. However, 82 is still quite highly predictive and sensitive. So the study is continuing until we reach a sample size of 150 participants. But so far it's promising, and we're still identifying that SNPs in the TIR pathway are predictive of risk. So we're hoping to have this study finished by the end of the year. But as many people know, we can't predict toxicity using genetics alone, so we have to understand what these SNPs do in particular on cytokine secretion. So we're also conducting another study, which I presented this morning, identifying a genotype-phenotype relationship with these SNPs and with secretion of IL-1 beta and TNF-alpha. However, the idea is to create a predictive platform that will allow us to personalise the supportive care measures for patients to not only reduce their severity of GI toxicity, but also to improve their quality of life whilst they're having cancer therapy. I'd just like to thank for my acknowledgement.